Hello and thank you for joining us. I'm Dr Benjamin Armstrong and I'm a clinical microbiologist and the Director of Microbiology at Douglass Hanly Moir Pathology. I'm also a Palawa man and today we are coming to you from Gamaragal land in Sydney. I'd like to start by giving my respects to Gamaragal people and Gamaragal country, the land, water and community, and to all country and community across Australia wherever you might be listening or watching from. Today, we are here to talk about alopecia or hair loss. Hair loss is often dismissed as a cosmetic problem, yet it intersects biology, psychology, and systemic disease. This episode unpacks alopecia from both a clinical and pathological perspective. Today, we're learning about how hair loss matters medically and how pathology guides diagnosis and management. I'm joined by two international experts on alopecia diagnosis, treatment and testing, Professor Vicki Howard and Dr Maddie Gorji. Welcome to you both.
Thank you.
Vicki, can you please introduce yourself for our listeners?
Of course. I'm an Associate Professor of Pathology at the University of Notre Dame. I am a Fellow of the Royal College of Pathologists of Australasia. I'm an Honorary Fellow of the Australasian College of Dermatologists. I'm a Fellow of the College of Pathologists where I hold the Diploma in Dermatopathology. I also have international board certification in dermatopathology. And on a local scene, I'm the team leader of the Alopecia working group at Douglass Hanly Moir Pathology. I was lucky enough to do my advanced training at St John's Institute of Dermatology in London, where they have a very busy hair unit. And I was able to soak up the experience of being there with a high number of cases. And also I was able to bring back protocols for the laboratory handling of hair specimens, which I have modified for local factors. And the reason behind the modification is that dermatology trainees in Australia are often suggested to do two biopsies, one of the area of alopecia and one from the occipital scalp, which is an androgen insensitive area and works as a normal control. So I've taken that into account in the local variations of the St John's protocol.
So you're an Australian pioneer in this condition.
Well, I've sort of done it my own way with what I've learnt. So I've been in a very fortunate position.
Welcome, thank you.
Thank you.
And Maddie, is it true that you're one of only 3 people in the country who hold dual specialties as both a dermatologist and a pathologist?
Thanks for having me, Ben. Yes, that's correct. I did my pathology training first and I worked as a dermatopathologist for a few years before I do my dermatology training. I also have dermatopathology diploma from European Dermatopathology Society. I have interest in research and I am an invited editor of Australasian Journal of Dermatology. But more related to today's topic, I have a special interest in alopecia and hair pathology. I am enrolled in evidence-based hair fellowship, and currently I work both as a dermatopathologist at Douglass Hanly Moir Pathology and as a dermatologist in clinical practice.
Welcome to you as well. Thank you.
Thank you.
So alopecia nominally might not seem like it's a very debilitating condition, but it can be very stigmatising and strongly affect a person's well-being. Maddie, starting with you, can you tell us what alopecia is?
Very good question. Alopecia is the medical term for hair loss. The word alopecia comes from a Greek term, alopex, meaning fox, And the reason is the alopecia initially observed in foxes suffering from a mange. As we all know, hair doesn't play a vital biological role in human beings, but it plays a significant psychological role. In some individuals, hair is closely tied into their self-esteem, identity, and social confidence. So hair loss can be quite distressing. Also, hair loss and hair shedding can be the first manifestation of a more important internal medical condition. For example, thyroid disease, both hypo and hyperthyroidism, and iron deficiency anemia, they can present with rapid onset hair shedding, which we refer to as telogen effluvium. Some alopecias are autoimmune conditions, and they can be associated with other autoimmune diseases. For example, alopecia areata. It can be associated with Hashimoto's thyroiditis, diabetes. So alopecia is not a purely cosmetic condition, as you mentioned. It's a medical condition. It has very important psychological impacts in some patients. It can have important underlying medical triggers and systemic associations. So in my opinion, it must be properly assessed by a medical practitioner familiar with hair disorders, properly investigated and thoroughly assessed, accurately diagnosed, and appropriately managed.
And Vicki, can you tell us a little bit about what is normal when it comes to hair growth and structure?
Well, there are 3 types of hair. There's hair called lanugo hair, which is present in utero in developing babies, and it has a role in protecting the skin and also in temperature regulation. And that hair is shed at about 7 to 8 months gestation, where it is replaced by vellus hair. And now vellus hair is the hair that we have on arms, torso, legs. It's baby hair or very fine hair, and it's not pigmented. We also have terminal hair, which is the hair that is on the scalp, the axilla, which is the armpit area, as well as the genital region, eyebrows and eyelashes. So we have different types of hair. But in common, we have hair shaft structure, which has a hair bulb and has a dermal papilla, which supports it with vascularization. And that's the point where the hair is actually growing from, and the point at which the pigment is placed into the hair shaft, which will determine the colour of the hair. There is a suprabulbous stem, and then we travel upwards to the isthmus, where the oil glands, or sebaceous glands, as they are medically known, enter into the hair follicle, and that would present as slightly greasy hair because of the sebum that is placed into the hair follicle. It opens onto the surface via an ostium. The hair cycles normally, and it goes through 4 cycles. The most important is the anagen phase, which is the actively growing phase. And that can last anywhere between 2 to 7 years. And that will determine how long your hair will actually grow, how long it's in the anagen phase. And at any one time, it's normal to have about 85% of your follicles in that growing anagen phase. This is followed by a catagen phase, which is a transition where the hair starts to shrink and loses its vascularity. And that lasts between 2 to 3 weeks. And it involves at any one time approximately 5% of the hair shafts. Then we move into the telogen phase, which is the resting phase, and that can last for up to 3 months. And at any one time, approximately 10% of follicles are in that phase. Then we have exogen, which is the period during which the hair is shed, and it is normal for hair to shed 100 to 150 hair shafts a day. So maybe that's a little surprising to some people, but loss in that order is in the normal range.
Is that just on the scalp, or is that the whole body?
That's the scalp.
100 scalp hairs seems like an extraordinary
It does seem like a lot, and in your hairbrush that is going to look like a lot.
And Maddie, what is the most common type of alopecia that you would see in your clinical practice?
One of the most common types of alopecia in my practice is androgenetic alopecia, also known as a female or male pattern hair loss. As the name suggests, androgenetic, it's a genetic condition. It has a complex polygenic background, and genes can be silenced or activated by environmental triggers. And it's important because when I tell some of my patients about their condition being genetics, they ask, but my parents both have very good hair volume. It's possible. Androgenetic alopecia has inherited background, but it can skip generation because of the environmental triggers. So what happened in androgenetic alopecia is hair in certain part of the scalp in people with this genetic background are more sensitive to male hormone or androgen. So under the influence of male hormone, the hair, the terminal normal hair turn into thin, fine, baby or vellus-like hair. So what happened in earlier stage, we don't really lose a lot of hair, and we don't have a significant reduction in the number of our hair follicles, but it's the quality of hair which has changed from a terminal thick normal hair into a thin vellus-like hair, which causes the reduction in hair volume. The condition usually can start as early as early 20s or sometimes late teenage years, and it's usually very slowly progressive. Diagnosing of the condition is usually clinical and based on seeing the miniaturization and anisotrichosis, meaning variability in the size of hair shafts under trichoscopic examination. But sometimes when we are in doubt, we take biopsy, or if you're thinking there might be a secondary pathology happening, we take a scalp biopsy. From the blood test point of view, it doesn't need any testing for diagnosis. But again, if you're in doubt, if it doesn't fit typical or classical androgenetic alopecia, for example, it starts too early in a 13-year-old boy, or it's rapidly progressive, it just doesn't fit with typical androgenetic alopecia, and we are thinking of there might be some sort of hyperandrogenism or abnormal hormones, we consider doing hormonal testing. New studies have shown some association between androgenetic alopecia and metabolic syndromes. So again, in an appropriate clinical setting, it might worth considering testing for blood sugar and lipids in patients with androgenetic alopecia.
So it's normally a clinical diagnosis, but the biopsy helps when
Absolutely.
There are red flags or it's not 100% clear.
Absolutely, yeah.
Okay.
For sure.
What about like thyroid tests?
Good question. We don't normally do thyroid tests in androgenetic alopecia. We do that in telogen effluvium, for example, when we are thinking of thyroid disease triggering the condition, or as an investigation for other autoimmune associations in alopecia areata. So it's not a classic test that we order in a typical androgenetic alopecia, but it plays a significant role in other types of alopecia, such as telogen effluvium and alopecia areata.
And Vicki, now Maddie's taken a biopsy because she's not sure. What happens next and what are you looking for?
We recommend a 4mm punch biopsy to be submitted for assessment, and it is actually handled in a very special way in the laboratory. So we have a number of trigger words in the clinical history that flag the specimen as an alopecia specimen to be handled in accordance with the protocol, as I've indicated. It's important that we cut it in horizontal sections because that way we can capture every single follicle that's actually included in the biopsy. We can work out its size, we can work out what phase of the hair cycle it's in. And for androgenetic alopecia, we are looking for what's called miniaturization. So there's loss of the normal number of terminal hairs, which are the long, thick hairs, replaced by baby fine hair, and we get a reduction in the terminal to vellus ratio, often falling below 3:1, with a normal range of greater than 7:1. So that's what we're looking for in androgenetic alopecia. And I have a slide of one of the examples from a case which has been de-identified, just showing the circular nature of the biopsy. And down the microscope, this highlights the hair follicles to their best advantage. I've taken a number of photographs which will be in the resources below so people can have a look at it in their own time.
And Maddie, how do you manage these people with androgenetic alopecia?
There is a main group of medical treatments for androgenetic alopecia. The first group is anti-androgen medications such as spironolactone, most commonly used in female with pattern hair loss. We have minoxidil, which can be used for both male and female patients. And we have 5-alpha reductase inhibitor group, finasteride or dutasteride, which mainly used for male patients with pattern hair loss or postmenopausal female. Because of the potential teratogenic risk, we try to avoid that in perimenopausal patients. These medications can be used topically or as a tablet systemically. Obviously, topical treatment is much safer, which with less risk of side effects, but it's going to be less effective compared to the systemic ones. Then we have another group of treatments which I count them as an adjunct treatment, meaning that monotherapy with these options may not be very effective, but in combination with the first group, they can provide an extra benefits for the patient. There's treatments such as PRP or platelet-rich plasma, microneedling, and low-level laser light therapy. And hair transplant would be the surgical option for treating patients, usually in more advanced stages of androgenetic alopecia, when purely medical treatment is not going to provide sufficient cosmetic outcome for the patients.
And so for this condition, the biopsy is obviously incredibly useful to determine that the patient's getting the correct therapy. Vicki, how does this condition look on a biopsy? And how does it differ from other types of alopecia?
Well, it's a non-scarring process, so in that there's no permanent replacement of the hair follicles by scar tissue, and it's a non-inflammatory process. So we get variation in hair shaft diameter, which correlates well with Maddie indicating on trichoscopy that there is a differentiation in hair shaft diameter, and I see that down the microscope. So I'm looking for the features of miniaturization to support the hypothesis of androgenetic alopecia, but I'm also looking for other causes to exclude that there isn't a contributing factor of another alopecia process or an inflammatory process. Patients with scalp psoriasis can lose their hair, and that doesn't stop them having androgenetic alopecia as well. So I'm on the lookout to exclude anything that's a secondary contributing factor to the hair loss. So we do the same investigations for both male and female pattern hair loss, looking for what's called miniaturization, which means reduction in the number of terminal hairs and increased number of vellus and vellus-like hairs.
And Maddie, you mentioned alopecia areata. How does this different type of alopecia present clinically?
Alopecia areata is another common type of alopecia. And as I mentioned earlier, it's an autoimmune condition. When I describe that to my patients, I tell them that for some reason, which in many cases we can't find the trigger, it's your immune system has become overreactive and attacking your own hair follicles, recognizing them as an enemy. And it causes hair fall and hair shedding. It is a very unpredictable alopecia, and it's hard to know how it's going to behave. In most cases, it's a chronic condition. It starts as a solitary or a few patches of hair loss on the scalp or facial hair or body hair. which can regrow by itself, but it has a chronic tendency. So this pattern can come back again in a year or in a couple of years' time. Less commonly, the condition can progress, causing alopecia totalis, meaning complete loss of scalp hair, or alopecia universalis, meaning complete loss of scalp and body hair. There are some risk factors telling that there's going to be a more aggressive behavior in a patient, and that is early onset alopecia areata, strong family history or personal history of alopecia areata or autoimmune conditions, when it starts rapidly progressive from the beginning. So these risk factors increase risk of a more aggressive behavior with alopecia areata. But again, it's so unpredictable and we just really don't know how it's going to behave in every single individual. Again, diagnosis of this condition is usually clinical, but when we are in doubt, when we have other differential diagnoses, we do a punch biopsy and send it to Vicki for histological examination. And blood test-wise, there's no testing needed for diagnosis of alopecia areata, but looking for other autoimmune associations, I think is very important, particularly thyroiditis. And in this case, we request a thyroid function test and thyroid autoantibodies in patients with alopecia areata.
And Vicki, how does alopecia areata look on the biopsy?
It actually has a distinctive appearance. As Maddie indicated, it is an autoimmune condition, and what I see is lymphocytes, which are a type of white blood cell, and they are attacking the bulbar epithelium of the hair bulb. And in a classic case, we call it swarm of bees, just highlighting the nature of the lymphocytes around that hair bulb. I do have a photograph in the resources at the bottom of this podcast, which is quite impressive. I have a normal bulb and I have the abnormal bulb with the swarm of bees. So I'm looking for that, and it can be just very focal. It may not involve all of the follicles in the biopsy. In a 4mm punch biopsy, I expect 28 to 35 follicles, and it may only be 1 or 2. And that's why the horizontal sectioning is so important, to capture all of the follicles so they're available for assessment. In alopecia areata, there are also some secondary changes. For example, there is a miniaturization tendency, and there is also an elevation in the telogen count. But the classic finding is the swarm of bees with the lymphocytes attacking the hair bulb.
And have you ever had any surprises in one of your biopsies?
I have had a couple of surprises. There are 2 that come to mind. The first was a lady, mid-40s, came with the clinical history of bitemporal regression, and a biopsy was taken, and it had loss of follicles. It had some scarring, but not very much. It didn't have features of alopecia areata. It didn't fit with androgenetic alopecia. And at that point, I wasn't quite sure what the diagnosis was. So what I actually do when I have biopsies of that type, I pick up the phone and I call the dermatologists and we have a discussion about the case. And the dermatologist forwarded me some clinical images, which were very useful in this case because they indicated that the patient had very tight hair braiding, and it was a traumatic kind of alopecia related to chronic tension on the follicles in the setting of tight plaits. So that was a surprise. But once I saw the clinical photos, it all fell into place. So highlighting the importance of working very closely with pathology with the clinical side of things. I also had one patient, and I would like to emphasise that this is very rare and I have only ever seen it once in my 25 years of practice, was a patient who had alopecia secondary to a lymphoma, which is very rare, and I don't want to scare people, but it presented as alopecia. So that patient went on to be managed as lymphoma, and at last follow-up, the patient was doing well.
Actually, I have a question from you, Ben. Tinea capitis is one of the common types of alopecia in pediatric population. And what we do for diagnosis, we do skin scraping and hair plucking and send it off to the pathology lab for fungal MCS culture and a new test called PCR. Can you tell us a little bit more about this testing?
Of course. So tinea capitis, as you said, mostly affects children because it's most commonly one of the group of fungi that cause these infections called dermatophyte fungi. And tinea capitis is more commonly part of the microsporum group, which is zoonotic or from animals. And in particular, this one affects children because they tend to be a bit closer to our pets. So it's purely that epidemiological exposure that gives them the higher risk of tinea capitis. So the microsporum is a fairly common organism, even in Australian pets, and we do see it a fair bit in the microbiology lab. The scrapings and plucks that you send to the lab, we divide up and we still provide the full gold standard testing that you'd be used to of microscopy and culture. Those tests are a little bit slow, unfortunately. The culture takes at least sort of 4 weeks, although the microscopy is relatively quick, but they're not particularly sensitive. So now we have a new PCR test that picks up all the common dermatophyte fungi and has a much better turnaround time. So it's usually available same day as the microscopy. It gives you a name, which is really important, particularly for tinea capitis, similar to culture, but much, much more quickly. And tinea capitis, because it's caused by microsporum, has a slightly different susceptibility to different drugs. So most tinea or most dermatophyte infections we would treat with terbinafine, but the microsporum responds slightly better to Grisia fulvin. So it quickly redirects you from one drug to the other for those patients. Yeah. The PCR is very good. It's very sensitive. It's not perfect, but it's picking up in my lab around another 10% of cases over the microscopy in particular, but microscopy and culture together. And it's not impossible, but rare that we find one on culture that we didn't find on PCR. But still, the 3 tests go really well together as a package to make sure that we've got the highest sensitivity and specificity. But now, thankfully, much better turnaround time.
Yeah, absolutely. I found this PCR very fascinating. I do the test, and in less than a week, I have the answer for confirming the diagnosis of tinea, which is really good.
We've just got a new PCR actually in the last couple of months of this year that we're using as an add-on test for positive cultures or positive PCRs which have trichophyton dermatophyte fungi detected in them. And we can do that either on the specimen from the DNA extracted or from the culture. And it's a dermatophyte resistance PCR that we've just brought in. It is able to tell you whether the organism is going to be susceptible to terbinafine, because terbinafine resistance is a big problem that's unfortunately spreading through the community. It's becoming a global issue, whereas before we could guarantee that it would work. It's no longer the case. So we do have extra tests in our repertoire now to guide therapy as well, and that's, again, a very quick and easy test that we can provide at DHM.
Great. That's good.
And so the lab, I guess my lab at least, does have new things that are coming in the field of skin and alopecia, in particular for tinea capitis. Maddie, what is new or coming out or new on the field for the management of alopecia?
There are a lot of new medications coming out for different types of skin condition, including alopecia. For severe type of alopecia areata, we have a new medication called baricitinib, which is a selective JAK inhibitor, and it's now available in Australia and approved by TGA. It has a better safety profile compared to the older immunosuppressive medications such as methotrexate or cyclosporine or prednisolone, but it carries its own risks and benefits and needs to be discussed by individually before commencing treatment. But it's a very good medication, and many studies have shown regrowth of hair in patients suffering from alopecia totalis or universalis.
So next, if it's all right with you both, I think that alopecia is one of those conditions that has a lot of myths surrounding it. And I'd really like to have a rapid-fire myth-busting session. So first, can stress cause alopecia?
Stress is a known trigger for some types of alopecia, for instance, telogen effluvium or alopecia areata, but it's neither necessary nor sufficient by its own to cause an alopecia.
Okay, and can minoxidil cause hair whitening or discoloration?
The most common side effect of topical minoxidil is irritation and allergic contact dermatitis. Using topical minoxidil for a long time can cause a bit of buildup in some patients, but it's not a bleaching agent. So it's not a usual side effects of minoxidil.
And is minoxidil toxic to pets?
That's correct. Particularly in cats, but also in dogs, it can be fatal. So if you're using topical minoxidil, make sure that your pet doesn't come to your bed and doesn't lick your pillow sheet. Because of the lack of enzyme to metabolize minoxidil in cats, it can be very toxic for them.
And does a biopsy always make a diagnosis?
It doesn't always, but in many cases it does. And I think those cases where we can't come to a conclusive diagnosis, when we put our heads together, we can usually come up with a course for the patient and appropriate treatment and follow-up. It's very important that the dermatopathologist works closely with the clinician for the best results, particularly when it's not a straightforward case. And this can involve several telephone calls, the submission of clinical images so I can see what we're dealing with. All of that, it helps to a great extent. So there are very few biopsies at the end of the day that are not helpful.
And can rosemary or peppermint or pumpkin seed oil or any diet or supplement treat or reverse hair loss?
So about the rosemary oil or other essential oils, some limited studies have shown small benefits for patient with androgenetic alopecia, and it's because the natural anti-androgen effect of rosemary oil. But compared to medical treatments and the first group that I talked about, the effect is very, very limited. And bear in mind, topical oils, the essential oils, rosemary oil, can cause irritation to the scalp, can cause allergic contact dermatitis, which they can make the hair shedding worse. About the supplements, they can only help if there is a documented evidence of a nutritional deficiency. So yes, if you have low iron, if you have low vitamin D, low zinc, supplementation definitely help to improve their hair loss, but it's not recommended as a treatment for any type of hair loss.
And can alopecia regrow on its own?
Yes, it can. As I said earlier, alopecia areata is a good example of hair loss which regrow by itself, but treatment can help facilitating this process.
And are all forms of hair loss reversible?
No, that's not true. We divide alopecias into scarring and non-scarring, and that's a very important distinction to make because once the hair follicles are replaced by scar tissue, which is fibrous tissue, they are no longer able to cycle and they are permanently lost. So it is very important to pick up scarring alopecias early when treatment for the inflammation can still save the hair follicles. So it is actually very important to pick that up early. But once there is actually established scarring, the hair will not grow back.
Thank you both. Myths busted. Vicki, can I ask if listening doctors can take home one key fact or one thing from you today in terms of
Sure.
diagnosis or management of alopecia?
Absolutely.
What would that be?
And I know I've mentioned it before today, but one of the best things you can do is a deep 4mm punch biopsy. Send it in with a clinical history clearly indicating that it's for alopecia, so we can triage it and examine it according to the protocol. If there's any diagnostic uncertainty, clinical images are always gratefully received and often are very helpful in my assessment of the hair follicle. So my take-home message would be, if we're going to do a biopsy, let's make it a good one.
Great. And Maddie, do you have anything to add for the people at home?
I have two take-home messages. One is alopecia is not a cosmetic condition. It's a medical condition. As I mentioned earlier, psychological impact of this condition shouldn't be overlooked. Associations, internal triggers must be properly assessed. And second message would be, please don't listen to social media about the assessment and treatment and diagnosis of alopecia. See your medical practitioner, your doctor, for a proper assessment and diagnosis.
Thank you. And if you're a doctor or patient listening at home, we have a whole host of resources on the podcast page if you just scroll down on alopecia, including the wonderful slide images that Vicki has described and provided for us to demonstrate some of those histological findings that she mentioned. So, Dr. Maddie Gorji and Professor Vicki Howard, thank you both so much for your generous time that you've given us today for talking to us. And thank you both so much for telling us about how you both work together so closely to help the hair of Australia.
Thank you.
Thank you.